All right, today we're doing something a little different. You're going to step into the shoes of a doctor. We've got 2 medical cases, we're going to look at all the clues, and then you have to make the call. You ready to scrub in? Let's do this.
So picture this. You've got the white coat on. For the next few minutes, you are the clinician in charge. A patient is counting on you. Let's see how you do.
Okay, case number 1. The scene starts a few days after what was supposed to be a totally routine surgery. But, as you're about to see, things are definitely not going to plan.
So, here's our patient. He's a 45-year-old guy just 3 days post-op from a knee surgery. Now, instead of feeling better, he says the pain is actually getting worse, and he's starting to run a fever. Right away, those are some major red flags.
Okay, the physical exam gives us a lot more to go on. We can confirm he's got a fever. And the surgical site itself, it's angry. It's red, it's warm to the touch, and it's tender. And here's a huge clue. The wound has actually opened up a little, and there's some clear yellowish fluid coming out. To top it all off, his heart is racing at over 100 beats per minute. The plot is definitely thickening.
Now we get the lab work back, and this gives us some hard data. Just look at his white blood cell count, the WBC. It's at 14.5, which is way above normal. Think of your white blood cells as the soldiers of your immune system. A high count means the army has been called out in full force. And look at his ESR, which is just a general marker of inflammation in the body. It's through the roof at 65. These numbers are practically screaming that the body is fighting something serious.
Okay, so you've got the symptoms, the exam findings, and the lab data. It's time to make a decision. What's your diagnosis? Look at the options here. Which one fits all the pieces of this puzzle?
All right, pencils down. Let's see if you were right. We're going to break down all the evidence and pinpoint exactly what's going on with our patient.
And the correct diagnosis is C, a surgical site infection, or SSI. If you picked that one, nice job, you nailed it. All the classic signs, the fever, the inflammation right at the wound, the discharge, the lab results, they all point directly to this.
A surgical site infection is pretty much exactly what it sounds like. It's an infection that pops up right where the surgery happened. And it's defined by those textbook signs we just saw in our patient. You've got the fever, the redness and warmth, the pain, and that discharge from the wound. He literally checked every single box.
So you might be wondering, well, why isn't it just cellulitis? That also causes red, warm skin, right? And that's a great question. But the key difference here is the source. An SSI is tied directly to the surgical incision, and, this is critical, it often has discharge coming from the wound, just like our guy. Cellulitis is a more general skin infection that can happen anywhere.
And we can knock out the other options pretty quickly. A DVT, that's a blood clot. That's not going to cause a fever or discharge from a wound. Septic arthritis, that would cause intense pain deep inside the knee joint, not just on the surface. And osteomyelitis, which is a bone infection, well, that's more of a long-term thing. And we didn't see any signs of it on the x-ray. The evidence just doesn't fit.
Excellent work on that first case. Now, let's reset. You're in the emergency department. A new patient just rolled in. This time, the challenge isn't just figuring out what's wrong, it's deciding the right thing to do about it.
Okay, meet patient number 2. He's a 30-year-old man who's got a deep cut on his forearm from some broken glass. It's a pretty big one, about 6 centimeters long, and yeah, it's actively bleeding.
So during the exam, what we don't find is actually just as important as what we do. He can feel and move his hand perfectly, which is great news. It tells us the major nerves are probably fine. We can feel a strong pulse in his wrist, meaning the main arteries are likely intact. And even though the cut is deep, we don't see any exposed tendons. In medicine, these kinds of negative findings are a huge relief.
Now we check his labs. And what a difference from our first patient. Everything here is totally, completely normal. His white blood cell count is fine, his hemoglobin is stable. This just confirms what we saw in the exam. There's no sign of a big infection brewing or any major blood loss.
So the big question this time isn't what's the diagnosis, but what's the plan? Given everything you now know about this patient, what is the single best step to take right now?
This is where you have to think strategically, weighing the risks and benefits of every possible action. Let's find out what the right call for care really is.
And the correct answer is A. The right move here is to thoroughly clean out the wound and then close it up with sutures. It's the most direct, effective, and standard way to handle this kind of injury.
The logic here is pretty straightforward. Step 1, you gotta clean it out.
that irrigation is absolutely key to preventing an infection later. Step 2, you close it up to help it heal and, of course, to stop the bleeding. And finally, step 3, you just make sure his tetanus shot is up to date. It's a simple, clean, and effective plan.
And it's just as important to know why the other options were wrong. We don't need to rush him to the operating room because there's no sign of any deeper damage to nerves or tendons. We can't just send him home because leaving a wound like that open is asking for an infection. And we don't need to call a specialist because his circulation is fine. It's all about matching the treatment to the evidence you have in front of you, not over or under treating.
So, let's step back from these two cases for a second. What do we actually learn about the way a doctor thinks? What is the clinician's mindset? Well, it really boils down to this 4-step process. First, you gather all your clues from the patient and your exam. Second, you use objective data, like labs, to test your theories. Third, you use the process of elimination. Knowing why something isn't the answer is just as important as knowing why it is. And finally, you match your action to the evidence. It's an incredibly powerful way to solve problems. And of course, behind all the science, there's always a bit of art. As Voltaire once said, sometimes our job is to support the body while it does its own amazing healing work.
You know, this structured way of thinking, gathering evidence, testing ideas, taking targeted action, it doesn't just apply to medicine. It's a framework you can use to solve almost any complex problem. So here's a final thought for you. Where in your own life could you apply this clinician's mindset? Thanks for joining me.